And it is my great pleasure to introduce Martin Bohus to you in our series of interviews with leading experts. And we sure have a leading expert with us. Martin, let me briefly introduce you. You are a professor of psychiatry and psychotherapy. And in my words, I think you are the leading figure for DBT, dialectical behavior therapy, in Germany, definitely. You founded the DBT network in Germany, but you are also internationally really well known. And in your early work, as I perceived it, you focused on adapting DBT for inpatient settings, which was really important in Germany. For those who are not aware of this, in the German healthcare system, there is room and possibility to treat for longer treatment, inpatient treatments than in other countries. And later on, the other very important research you did was turning to trauma and when to treat trauma and PTSD, complex PTSD, and also, trauma in BPD patients. And you published this RCT, the release trial in JAMA Psychiatry in 2020, which I think was also a milestone for the field, so that we all know that, yes, you can treat trauma and you should treat trauma early. So besides that, I always admired your ideas and the energy with which you went to the field and told people what the next steps should be and how to do it and how to carry it out. And this all started earlier, and you also had, in 2010, you organized the first ESSPD Borderline Congress, and it was then only the Borderline Congress. So how did you come up? What was driving you to organize that first conference on borderline personality disorder?
Oh, as first of all, Babette, thanks for interviewing me, and I feel really privileged and honored. And it's a little bit funny that you interview me now as a privileged person, since actually the first person I invited to give a talk on personality disorder was you. So I started learning from you, yeah. And I always admired you and your work. And in the beginning, at least, I said, wow, you are really somebody I'm looking up. So we are on the same level, yeah. But thank you. Now you are in this role interviewing me, and I can play the elder statesman. So your question was, how did we come up with this first Congress? And actually, it was, it was, as ever happens, it was just a beer idea. I was drinking a beer with a friend of mine, and somewhere in Berlin, and said, why shouldn't we organize the first Congress on borderline? So that was it. And this is some kind of say, okay, if I look at this, it has something to do with my personality profiles. I would characterize me as a little bit on the ADHD side, a little bit on the high risk seeking behavior. So I'm not very scary and not very anxious. And I have a lot of fun organizing things. So at least starting to organize. I'm very bad in finishing. I'm good in initiating it. So yeah, that was the idea. And then I said, okay, there's no borderline Congress in the world. And I had the strong feeling that it's time to create something that what is very specific for this group of clients. Those times we also didn't have a journal on borderline. This is the second thing I did afterwards, together with Christian. So I thought it's an important disorder. It's under-researched. It's not in the scope where it should be. We have about, let's say, the figures, at least 1.5% of the population. It is one of the 4 severe psychiatric disorders, and it doesn't have the place it needs to have. And for that reason, I thought, why should we do we have a Congress on eating disorders, on ADHD, on everything, but not on borderline? So that was it. And I said, okay, then let's do it. And I choose Berlin since it's German, and it's I thought Berlin was attractive, and then I did everything. I started everything by my own. I went to a Congress organization and said, "Could you help me?" And I went to a Congress venture, and they said, "Could I book it?" And then there was a little story. Let's say Pentecost was around about. I was in Sicily at the beach, and they thought, "Wow." Now I figured out I needed 700 people to come to the Congress to have a break even, 700. And actually the risk was completely on my side. This means the rest I had to pay personally. And I didn't tell it my wife. So sitting at the beach, I said to her, "Listen, honey, we may have a problem. Since if we don't get 700 people to Berlin, maybe we are bankrupt." And she said, you fool, yes. Now start working, stop talking, go on the phone and call. And then I worked for a month. I called everybody I knew. And then we came up with more than 1,000 people in Berlin. And after that, I said, maybe it's too risky to do this every year on my pocket. So it would be nice to have an organization. And then Thomas Renne those times had the idea coming up with the European Society of for Personality Disorder. And I said, okay, let's join this thing. You set up the European Society and I bring the Congress in it. So that was how it worked. And then from that time on, the second Congress was organized by the European Society. And it was a great release for me since I didn't have to back up it personally. I'm not rich. It would have been a disaster. That's it.
Yeah, well, as you mentioned, you like taking risks, right?
Yeah, a bit.
Yeah, I introduced you with from my perspective. What do you consider to be your most important contribution to the field so far?
You mean to the borderline field?
Yes.
I wouldn't take me too seriously. I would say the most important thing I did is learning from Marsha, and it was the milestone for me. Meeting her, learning her to know, and I had a long phase before I met her. I was trained as a psychoanalyst. I was trained as a behavioral therapist, both, which created a lot of tension. I was very nervous all the time. I had the feeling I didn't really get it where I want to go. I had a lot of energy, but no aim. My first career was an immunologist. So I did really basic research for years, 4 years. I published in Nature in immunology. So, and I think this had no impact directly on psychiatry, but I learned how to think scientifically from the very scratch. And in the first 1 or 2 years when I was in psychiatry, I was completely upset by this crazy way how social researchers created science, and I was very, very angry about how psychotherapists try to behave like scientists. So it took me a long time, 2-3 years, to take this serious, that this kind of social science is any kind of science at all. Since if you come from biology, I learned basic genetic immunology. You learn to be very strict and very concrete, and you don't publish anything which is not really proven. So in the lab of my teacher, I worked a year in just contradicting myself. This means I stood up in the morning at 7 o'clock and went to bed at 11. And day to day, I did the experiments to falsificate my own assumptions for a year. And then I was ready to publish. Mm-hmm. So I learned it very from the scratch. And this is a thinking where I said, this is important for me, since for me, science is the most important thing. And it takes it still takes a long time till we really figure out the basics and principles of scientific-based psychotherapy. Mm-hmm. And Marsha is a genius, definitely. What she wrote in this book is, I think, I don't know how she did it, but it was something like a rush. She wrote it in 2-3 years, and I was very close to her. And years later, she also said, "Oh, let's look back what I've written there, since sometimes she didn't understand her own treatment. It was really a big issue, which is very profound, very condensed, very deep, and you still can go into it and select things which we just start understanding. And the second thing is Marsha did it, and the second thing is Marsha was very open to science. She was extremely ambivalent. Of course, she was a guru, she was a prima donna, she was very charismatic. She was fighting the whole life. She was experienced some kind of borderline herself, but she always believed in science, and she was able to really question herself and trust the data. And this is my basic thing, my basic understanding with her is exactly this. It means I'm very good in conceptualizing, creating ideas, convince myself and others. I think I am also quite charismatic. What is the problem? Since people start believing me things, and sometimes you get seduced by these patterns, and you start believing yourself. And really having in mind, don't believe yourself, not a word, as long as you don't have the data. And this dialectics, coming up, conceptualizing something, developing a treatment for 10 years, putting all the money on one thing, creating a manual, convincing people to follow you and to put their careers on one risky study, let's say this DBD PTSD study, it takes 10 years development. And then if you don't make it, it's just garbage. And then saying, okay, if we don't get the data, then it's simply for nothing. And this is something, yeah, a complicated thing. On the one hand, you have to trust the things. On the other hand, you have to criticize yourself. And yeah, so.
Yeah, well, you said it. It's a dialectical process, right?
Yes.
And coming back to what you mentioned earlier, that you were trained in psychoanalysis and in behavior therapy, and I read, preparing for our talk, for our interview today, I read that you also studied philosophy.
Yeah.
So why didn't you become a philosopher?
Oh, I passed the exam. That was okay, and I was just ready to do the last exam. But then the political riots in Germany rose up. So we had this. In Germany, we say this Krakus, house occupation things. I'm a very left-wing political person, so always been. And we had riots. So, and that was so overwhelming interesting that that I quit philosophy and went into politics. So I did documentary films and newspapers and occupying houses, hanging on the street. And I didn't have a house for a flat for myself for 3 years. So it was no time for studying. I was happy to finish the medical study and survive on the streets.
So there was action and less.
It was action and adventure, and yeah.
Okay. Yeah. So I also said that you always, to me, you always come up with new ideas, or where should we go? What should we do next? And this is something I would also like to ask you. What do you think? Where should the field of, on borderline personality disorder, where should we go? What should we do? And yeah, or maybe let's start. What are you working at the moment?
Okay, what I'm working at the moment.
Yeah.
Let's say I learned a lot preparing designing the treatment on complex PTSD. I really learned a lot. Learning a lot means this dialectics between conceptualizing, treating patients, failing, then you get an idea of how you can help about 50–60%. You go for the non-responders, you try to clinically understand it, you go interviews, and then you get deeper and deeper and deeper into the problems. I love this kind of work. And I would say now, after we have treated about 1,200 patients, and of course I didn't treat them, but I have a lot on supervision, and I have this senior consultant position. So whenever something goes wrong, we call this serious cases or something, then they consult me, and I take my time to talk with the client and try to understand what's going on and thinking out of the box and not following the manual, but really trying to really understand what's happening. And this gave me at least an idea that I start to understand the problems of the sequela of repetitive, long, ongoing, early abuse, sexual abuse. The impact on not only the trauma memory, but impact on a self-concept based on complicated emotions like self-disgust, development of guilt and shame, all these complex mechanisms. And also the consequences then on their interpersonal behavior, with problems of mistrust, and so on. And after, let's say, 10, 12 years of work on that, I finally come to the situation that I say, I don't really see the difference between a sexual abuse and a very early, pervasive, interpersonal traumatization. So from two different approaches. The one thing is the phenomenology, where I say complex PTSD is not that much different from borderlines with PTSD. I know you understand the topic, so I think, yes, a lot of people now start thinking about this. There are some tiny differences, but I think it's a political issue that in the States, they want to have a strong difference. Why? Since it's a question of insurance companies again. If you say complex PTSD is very similar to a personality disorder, then the veteran administrations don't pay anymore. So let's always have in mind what is the political background has impact on nosology. From my perspective, I looked at the data when we treated our borderline patients, full-blown borderline patients, more than 5 criteria, plus trauma. We did the trauma treatment only, and we looked at the borderline symptom list. We figured out an effect size stronger than 1.2, which means only targeting the trauma in a combination of exposure and revising or focusing on self-disgust, shame, guilt aspect is really an extremely effective treatment for borderlines per se. So I started thinking, why not really to reconceptualize the borderline concept, and let's think a little bit out of a box, taking them out from the personality disorder spectrum and see them as a group of clients who suffered from the sequelae of early and also double hit. This means problems with the attachment system, but also with the affiliative systems. This means early problems, but also during your peer group experience. Patients with a long ongoing experience of social traumatization.
Yeah.
And if
May I just ask you to give an example of what you mean with aversive interpersonal trauma or the social trauma?
Okay, let's say the discrepancy is simple. If you have a sexual abuse, you have your sexual abuse. This is a very physical experience, the first thing. But the second thing is it has an experience of disgust and so on. The other thing, an interpersonal traumatization means it's the old terminology of Marsha. She called it traumatic invalidation. And traumatic invalidation is, from my perspective, simply means that your social experience that don't meet your social needs. Yeah? This can mean that you have really a very harsh social neglect. Yeah? But it can also mean that you have an ordinary family, but you are super sensitive and needy. This is the example what Alan Frasetti always gives. If you have a strong sunburn, if somebody just touching your skin, you act like somebody really hurt you. So it's the delta, the difference between the needs, the social needs of attachment and affiliative system, and what you can get. Mm-hmm. And I think everything can be explained from that perspective. And if I would have to choose, I would say, let's take borderline, put it in the new stress-related disorder spectrum, put it close, near, complex PTSD, and let's treat it as long-term sequela of interpersonal traumatization. This would have a lot of consequences, since if you think from the trauma perspective, this would mean, yes, we should really start thinking about the specific emotions and assumptions. And also what we now do, you asked me what I'm working on, is I try to more or less copy the DBT PTSD treatment now to apply it in borderline patients without sexual abuse. And yeah, so this means we have 50% who report sexual abuse and 50% not. And we take those 50% who don't report sexual abuse and provide them DBT plus exposure, really exposure, standardized, structured exposure towards traumatic invalidating experience. So I have the assumption that we have to do with, like in the trauma treatment, you always talk about trauma networks. And I say, yes, all borderlines patients suffer from what I call now core emotional networks, which has the first core emotional network has to do with abandonment, an extremely fear of being left alone, which is not simply being lonesome, but existentially, like a 3-year-old girl. We have all these biographies now. 3-year-old girls put in front of the door in the middle of the night and say, okay, you have been bad, stay there and wait till the wolves come, and so on. So this is this is an existential fear. Yeah. And these are anchored in networks like trauma networks, and our patients try to avoid this as hell. This is the one thing. The second network is the affiliative network. This means it has to do with social cooperation. This means making fear of making failures, being rejected, not being accepted as a cooperative partner, and so on. Research you have done. So if I sum up all the research, what we have, I could say it fits on the one hand on the problems with the attachment system, and on the other hand on the affiliative system. And the problem in borderlines is that if you have problems with one network, it's activating the second network. So this means, for example, you see some kids on the schoolyard, and they are talking about something, and our patient sees it, and she feels she's let's say they want to go to cinema and they don't take them with them. So this is a classic problem of feeling a little bit rejected, a little bit not seen. Yeah, this is the affiliative system. That would be easy to handle. However, in those clients now, the attachment system is activated. This means the first system is okay. Not only they don't like me, but this means I will be left alone completely and I won't survive this. So now we say these are two networks, like trauma networks, which are a little bit interconnected. And now we take exactly what we learned from the trauma networks. We work on exposure now. This means we look, okay, do we find cues which activate these networks, and we do a standardized protocol like 5 sessions, 6, 7 sessions in a row with taped and self-exposure homework and so on. And this is what we're testing now, in the hope that the fear of these networks, like the fear of the trauma networks, will disappear and go down, so that they are able to tolerate these aversive emotions and then have a better chance to create an adaptive level of behavior. In general, this is all already in DBT, but DBT itself, the standard DBT, is a little bit, I always call it, it's driven by the diary card, and it's an event-driven design. This means the therapist looks at the diary card, and then she takes the worst situation of the week, focus it, and then she makes a chain analysis and focusing on the dysfunctional emotions and cognitions which happen to this. If it's good, she also incidentally activates and works on these core emotional networks. However, Therapists try to avoid this. Patients try to avoid this. And whenever we look on what we know and learned on avoidance, therapist-driven avoidance of exposure, we know there are so many step outs that it may be a good idea to put this kind of exposure towards this avoided networks in a structured format that we say, starting with session 20 in DBT, in the new DBT body test, you have to start exposure with this key emotional networks. We call this SEDBT. This is structured exposure DBT, and it's manualized now, and we are now running the test studies, and I'm funded for the RCT. And actually, I don't know whether it works. It's just an idea, and I feel happy and privileged to do the next 5 years, 4 or 5 years, running the study together with Shelley McMahon in Toronto. It's very, very good to do it with her, since she's very, very clever and nice and gifted. And sometimes I have the tendency to go to let's say in German we say verbohrt, how you say, to in an idea.
English word as well. To focus, maybe to
hyper focus on an idea. So Shelley is always reflecting it a little bit. So this is the answer on the question.
Martin, may I interrupt briefly? Because you mentioned that you have a manual for the structured exposure DBT. Is that published? I'm sure people would like to know.
No. This is a very nice old tradition learned by Marsha, is never publish a manual as long as you don't have data. And I completely follow this. Yes, we have a manual. It's a research manual. It took me 3-4 years, almost really every weekend to write it. But I never will publish it if we cannot show that it's really superior to standard DBT, since it's no use to do this. So I don't publish anything.
And why do you think it will be superior to standard DBT?
Why it should be?
Why do you think it will be?
Why do I think it will be? Yeah. The point is that I think I've learned that if it's true that our patients are haunted by the fear of these two networks, the treatment of choice is exposure. And I think in standard DBT, it's somewhere in it, but it's often not done correctly. And so a lot of the problem in DBT is that we have so effective skills, which are really effective in reducing the level of distress on the short run. And I say sometimes these skills can be used on a very dysfunctional way, like in trauma. People have spent years in so-called trauma treatments where they worked on stabilization. What is nothing different than applying skills, but this doesn't change the problem. And I have the feeling that a lot of people, DBT is, since it's so effective in the skills application, it can also be abused or misused and prolongate the real problem, but give them some sort of, let's say, short-term behavioral control. And so I think very traditionally, maybe this is I think as a psychotherapist, I think go for the core problems. And the core problems from my perspective are these dysfunctional networks. And the best point revising networks is exposure. For that reason, I think it should be superior to standard DBT. If not, it's an investment of a few years, but I think it's worth testing it. And if it's better, it's just skip it in the garbage can.
Yeah, it reminds me of Mary Zanarini's talk last night, who also focused on experiential avoidance. I mean, that's what
exactly
we're talking about. That's the experiential avoidance of these social situations and the fear of being abandoned.
But we have two things when I say. The one thing is focusing on this experiential avoidance of fear of abandonment and fear of rejection. These are two different things. However, what I learned now is that we have to add something. Behavioral therapy is very good in replacing dysfunctional behavior by some kind of learning to control it. But when we talk about identity problems, or changing identities, taking them away the idea that they are worse, disgustive, and so on, and not replacing it by anything, it's not working. So now we are we added to this new treatment a very strong component of imagery techniques, where clients start really training up, setting up what I would call a new neural network. So it's a new psychoneural network. So on the one hand, we are trying to dampen the impact of this old psychoneural networks, and now we have to create new ones. And the new ones, I think this is also what I think the fifth wave in psychotherapy will be imagery techniques. This really starting, imagery technique means it's setting up new emotional, cognitive, and physiological and body-related networks, which are interrelated, and give you a sense of now what you want to create. And the idea is, here is Marsha's concept of wise mind. This means creating a sense of loving kindness, compassion, joy for others. Very important, not to be ego-centered, but really look for us, and serenity. These are four components which we take out of Buddhistic psychology, which is in DBT, but not that condensed. And we support our clients with imagery trainings. So they have, they get tapes. They listen to these tapes every day for 10 minutes by the voice of the therapist. Do it over and over and over. In the beginning, they have troubles, since of course they think I didn't deserve it and so on. We call it secondary thoughts, but it really train them up. And my experience is that this is an extremely powerful tool. We developed it also for the trauma treatment in the beginning, and there it's in the manual, and people love it. And they come out and say, yes, whenever something's happened, I activate wise mind. It's not that different than let's say hypnotherapeutic techniques, which are very resource oriented. I've been trained as a hypnotherapist as well, so I take things from other schools, bringing them together. And the trick is that you really encourage your clients for setting up a new network. Means repetition, 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 repetition. And it's boring for the therapist, but the whole need is that we really encourage our patients for an ongoing training. And this was also one of the really good things what Edna Foer invented. That he said, okay, we have an exposure, one session, and then they need 5 times to do it at home, and then a second one. We do the same thing in both, in the revision of dysfunctional concept, but setting up a new concept now again. So we said session, and then every day 10 minutes training. We are putting this on a contingency management, and this looks like quite promising. So I would say these are two ways: taking something away, replacing it by a more deeper, wisdom-driven perspective of yourself and the world, which opens yourself to yourself and the world.
Yeah. I have 2 more, one just comment, because I forgot to let people know that they can write the questions in the chat. Sorry. We agreed, Martin and I agreed beforehand that this is possible. So, if you have any questions, you can do that. But again, does this, the wise mind, and does that also relate to the concepts we heard yesterday about flourishing, about Mary Zannarini talked about gratitude, and talked about forgiveness. Do you see a connection there?
I think I love Mary. So Mary is somebody who's very close to the clients, and she's listening to the clients. She's more a silent developer and researcher, but she's very wise. And I love talking to her and listening to her, what she's saying, and it's very precious. It's more or less the same experience we had. My experience is also we have to help our clients to get something like a source, which is not, it has nothing to do with positive psychology. No? So saying to yourself you're worthy and so on doesn't work. But if you really create this kind of creating a source to your inner wisdom, what actually exists. And this was one of the gifts Marsha had. And she said, okay, she strongly believed, she was a Buddhistic teacher, and she had this experience of some kind of of inner wisdom. Let's keep it this. And the point is, you can train this up. It's not a one-term thing. You can, like any kind of mental process, once you have an idea, how it should feel like, you can create it. Look at Paul Gilbert's work. He has exactly brought the whole thing on the point. Get an idea of compassion, train it. But this, what we now are trying is expanding Paul Gilbert's work from not only loving kindness and compassion, but also joy for others. What is joy for others? Joy for others is that you are simply open your mind, that you can be happy if somebody else is happy. So this is an old saying of Thich Nhat Hanh. He says, if you can open your mind to the joy of others, the chance that you'll feel good, you expand it from 1 to 6 millions those times. Now it's 8 billions. Yeah? And I think a lot of our patients have extremely troubles to say, okay, as long as I don't feel well, I cannot be happy about others. So they are jealous. They are very ego-centered, and helping them to open their mind. Old saying of Marsha: learn to love without being loved. And a lot of clients are saying, I have to be loved first, then I can start loving. I have to find somebody and then I keep it. This has nothing to do with freedom. Yeah? Learn to love without being loved, and open your mind and help. And the point is, it's not just a saying. The point is how to get it in a skills way so that people can train it and then experience. And this is the new manual. So we put these things in a trainable, experiential, skill-based level. At least I hope that it works. And it's a little bit, and very often we say, okay, so that's it.
Yeah, well, I think we can go on, because this is really fascinating, Martin, and it's just really, I think you are right, and I'm really eager to see the results of this RCT, if this really will add something, because that's something that we have seen over the last decades, that since Marsha developed DBT, and Peter and Anthony MBT, and the TFP, and also schema-focused therapy, which, overall, and the, brief psychiatric management. So there are many, or steps, so many approaches that actually led to a better situation for patients with the BPD diagnosis. And I think this was really so impressive compared to the late 1980s or early 1990s, when oftentimes our patients weren't, patients with a borderline diagnosis were not treated as well as they are now. But of course, there's much room for improvement, and so I really appreciate your input in this, and I'd be really curious to see these results, and hope that yes, we can do better, and we can help patients better.
But I'm happy to share the manual with you. Yeah, so I can give it to you, and I would be very interested what you're saying, as long as you don't distribute it, since I really admire you as a very experienced colleage. And
I appreciate it, of course, and I promise I won't.
Just read it and tell me what you think about it.
Yeah. Well, Martin, I have some more personal questions, but before I come to these questions, I would like to ask you, because I assume that there are many young researchers and clinicians also listening. Do you have any advice to them, to the young clinicians and researchers?
Learn to love the patients. I would say it's a balance. It's always, research is a hard game. First step, if you're a researcher, I would say learn your techniques, be critical, let's say learn your instrumental thinking, and then try to treat at least 2 patients, and let the patients touch your soul. when I had the chair, every single researcher, and we were very good people, extremely good people like Uli Ebner and so on. I always asked them to treat at least 2 patients. And I think it was a great experience for them, since they suffered and they suffered in trying to understand them and so on, and really got into the needs of this patient. And this has influenced their kind of looking at the data, conceptualizing the research questions. So I am let's say, if you do clinical research, you have to at least have a really attachment to the clinical questions. If you don't do this, you will fail somehow. Maybe you can even do perfect research and publish it, but as long as you are not driven by the needs of the client, you can fail, let's say. Mm-hmm. And the clinicians, I would say, you are touched anyway. I would say, try to understand the research, since it's still, the crosstalks is complicated. Let's say if I listen to the standard concepts of classic borderline concept, like Kernberg's model or something, nobody talks about neurobiology. We have 20 years of neurobiology research and they don't take it. So I think still, as clinical researchers, as clinicians, try to open up your mind and try to understand research questions and what is valuable for you, and try to at least to discuss the transfer and be able to revise your concepts, since everything what you believe is good to help you to have a construct, but it's nothing like a construct. TFP is a construct, DBT is a construct, everything what we're working on. And you need it as long as you need it, but then you have to be able to revise it.
Mm-hmm. Yeah, I completely agree. And I realized writing a review on the topic of emotion regulation and working together with my colleague Tanja Lincoln and Lars Schulze, and Tanja came from a more theoretical perspective and the models, and I had the task of doing the clinical part. And I just said, well, before all these theoretical models of emotion regulation, there was DBT already developed, and and that came out of the clinical observations and out of the clinical daily practice. So I think, yes, we need both.
Completely right. You can add a lot of exactly to this question. Let's say emotion regulation. Let's say how many years have been spent with a model by Gross, which is only focusing on one aspect of emotion regulation. This means the present. This means how does an emotion regulate, but the anticipation of emotions is much more relevant for us as clinicians, and there's almost zero research. So I would say yes, but we need the cross-talk, we need to precise. Psychotherapists have to learn to think like scientists. I think this is very important. Mm-hmm. Try to think sharp with your heart.
Wow. Try to think sharp with your heart.
Yeah.
That's a good sentence, Martin.
You see, I'm growing older.
The motto, we have to come to an end. And the motto of our conference, or the theme, is, a better future and a life worth living, right? So Martin, let me ask you as my last question, what does a life worth living mean to you personally?
Open yourself. I would say one sentence: open yourself to others.
Okay.
That's the uppermost important thing. If you open yourself to others, you will get what you need and overcome the past and overcome your egocentricity. And I think this is a problem not only borderlines have, the whole world has. And if we open ourselves for others, you can contribute to the sake of the world. Yeah.
I don't think there's anything to add. Thank you so much, Martin, for spending the time with me and with the others here. And it's wonderful that you founded the ESSPD. Thanks for that. Okay.
See you. Thank you for all your time.
Bye-bye.
Questions.